Thank you, Kim, and thank each of you for being here this afternoon. I know there's some good football games going, but my Alabama and Georgia colleagues probably are not going to be here with us as the SEC conference has its championship game. Let me first, let's see. Do we go to the right? How do I advance our slides? Right button? I am pushing on the right button.
I'm the witness to that. He is pushing that.
There we go. All right. Just to give you a little background, if you're wondering who your state's Surgeon General is, there are only 3 states in the nation that have a Surgeon General. Michigan and Florida have 2 individuals that are, Michigan's is named by the Director of the Health Department to manage projects. Florida is the same as the Human Services Director. Mine is actually a legislatively codified position on the cabinet as the strategic advisor to the governor over the health issues. The governor can choose to have me, or he can choose just to have the agency head. So my role is not running programs, it's more on the strategic and advice piece. And as we come in today, and just to tackle the first one on the constitutional law, I think it's important for us to go back just a little bit on the history side to know why we got here. Constitutionally, health care is the responsibility of the states. It's not in the Constitution, and anything that explicitly is not in the Constitution is the responsibility of the states. But health care wasn't around in 1787 when we wrote the Constitution. In fact, we didn't even discover penicillin until 1928. We didn't use it until 1944. So I just want you to stop and think. The entire U.S. healthcare system that we have has been built in the last 75 years. And it's built and it's complex, and it couldn't be more screwed up if you tried to make it that way yourself. All right, 44, the other thing that happened is we, the United States, decided, actually, we didn't have much we were treating in 1944 either, but we chose to use employer-sponsored health care because in World War II, we put wage freezes in place and employers started offering health insurance. It didn't cost much, and that's why we're different than every other nation. The Hill-Burton Act were free funds to communities to develop hospitals in the 50s. It was the 60s before we modified the Social Security Act with Title 18 for Medicare and 19 for Medicaid. HMOs weren't legal until 1973. Employers and Medicaid started using them in the 1990s. We didn't cover most kids until 1997. We didn't have prescription drugs in the Medicare program until 2007. And 2 years ago, or a year and a half ago, we had the Affordable Care Act, which is a very disruptive act. Disruptive not meaning good or bad. It just put a lot of things on notice that it was going to change, and what we're doing with the change is going to determine what our future is like. Your state may not be facing the same pressure, but it probably is. These are our private sector employer premiums over the last decade. They have doubled for a family of 4, going from $6,000 to almost $12,000. The red portion is what families pay. The blue portion is what employers pay. We have people dropping out by the handfuls of the insurance market. It's not evenly distributed, where we have large employers that pay higher wages. Central Arkansas, where our capital and the largest companies are, we have higher coverage rates. Rural Arkansas, we have the darkest blue counties here, have over 30% of their 19 to 64-year-olds without any health insurance coverage in the prior 12 months. It's not just coverage. If you were a graduating physician or pharmacist, why would you move to one of those dark blue counties where 30% of the people aren't going to be able to pay you? Or also in those counties, when you do get sick and you use your credit card, personal bankruptcy, the highest cause is the uninsured rate in those dark blue counties, and it just is permeating and undermining our entire system. This is our Patchwork Quilt. We cover 60% of the kids in our state through either the Our Kids A or this Children's Health Insurance Program. We covered 3/4 of the nursing home beds for our seniors, frail elderly. We covered 60% of the pregnancies, but for adults in our state between 19 and 64, to be on Medicaid, you have to make less than $3,000 a year and have fewer than $2,000 in assets and be disabled for 12 months before you can get on. We don't cover many adults that aren't pregnant. So there's no safety net in our state for a floor. We in Alabama are the 2 leanest states in the nation in terms of benefit support for states. We're not alone, but we are the leanest. Now, Real quickly, you care for the elderly and you aid the poor. So to our legislative colleagues, file that away. It's my pearl. I give it to every governor, every legislator, because you'll hear people get them backwards. You care for the elderly, you aid the poor. The big difference between the two programs is Medicare is not needs-based as of today. Medicaid is always needs-based based upon poverty, income, and assets. So states get to determine where that limit is. The program is a federal-state partnership. The richer states have a lower match. The lowest match is 50 cents on the dollar. The highest match is 82 cents on the dollar. So poor states get a better deal, but they got to come up with their match. Richer states that have the money can come up with a match and basically turn $1 into $2. What you see, this is too small, but these are the 50 states, and each line is 50% of the federal poverty level. So 50, 100, 150, 200. It's oriented, the poorer states are on the left, the richer states are on the right, and you can kind of tell the richer states have gone up higher. Some states at 200% of the federal poverty level. For a family of 4, that's about $35,000 a year that they offer Medicaid to their adults. We're at 13% of the Medicaid, of the federal poverty level with the asset test and with the disability requirement. So any of those states below that bottom line are below 50% of the federal poverty level, and they stand to have huge gains if they choose to go forward and expand Medicaid up to 135%. Conversely, states that are above the second line, 100%, and those that are way above it aren't going to gain anything because the federal government's going to require them to maintain the effort that they're already putting in, and so those states are not having the debate and discussion that we're having now in the states that are below the line. Now, we've organized our efforts into 4 major areas, and I'm just going to touch on those because it gets to what we're trying to do around cost containment. The Affordable Care Act is a misnomer, in my opinion. It is just about getting people financial access. It does relatively little to contain costs. And I showed you that stair step on the private side. We've got the stair step on the public side in the same way. We've organized our state in 4 major areas. The first, red, led by our university and our health department, is workforce development. The second is payment improvement. The third is health information technology. And the fourth is our expansion. I'll kind of go in that order just quickly. On workforce strategic planning, for the first time, we actually have a strategic plan for all of our nursing schools and all of our physical therapy schools to think about what we're trying to do. And we're trying to move towards team-based care that uses health information technology, that has incentives aligned so that we get the right provider providing the right care at the right time. As a pediatrician, I am the most expensive well baby child provider in the state of Arkansas. And yet the clinic will let me do a whole week of clinic visits for well baby visits. I need a nurse seeing everybody, and I only see the sick people. That's how we ought to organize our team going forward, and that's what our strategic plan is trying to ask for. Health information technology, we've come from way far back in the pack to we actually were the first state to get approved for level 2 use clinical exchange of information on our information exchange. We got half our primary care providers that are on electronic records. We have our exchange in place. And we got the second largest Commerce Department grant to get broadband out into the rural parts of our state, because it's not going to do the doc any good to have an electronic record in his office if he's on a dial-up to get to the internet to go to the hospital to figure out what's going on there. Briefly on payment improvement, we're probably ahead, and I would ask you to pay attention. We have our largest carrier, Blue Cross Blue Shield. We have our second largest carrier, Qual Choice. We have our Medicaid program, all working together to change the incentives in the delivery system to move explicitly away from fee-for-service to an outcomes-based oriented payment system. We're doing that by using, on one side, patient-centered medical homes for routine care, and when something bad happens, to have a quarterback responsible for the entire episode. A hip replacement. Our orthopedic surgeons are responsible from the 30 days before the surgery to the 90 days after, and their payment is based upon that. And the way we're actually integrating this is the public payers and the private payers are publicly saying they want 80% of what they spend this year in this different payment system in 3 years. We've jumped off the cliff. We're not putting our toe in. It's not a pilot project. It's not a test case. We're moving the whole system in 3 years because we can't afford the fee-for-service unstructured system anymore, nor is our system going to be able to absorb an accountable care organization with full integration anytime soon. Here's how we're paying. We're setting thresholds for the episode, for the 120 days around the hip surgery. And if you're in the green, you get to share in the savings. If you're in the red, we're taking money back at the end of the period. We're live on 5 different episodes: hip and knee, congestive heart failure, upper respiratory infection, pregnancy, and attention deficit disorder. We have our state plan amendment. We're past the rule and regulatory process. The physicians started being paid differently in October. And the goal is to have 50 episodes out in 3 years. We don't believe we should expand Medicaid unless we are changing the payment system concurrently to be able to have an affordable system over time. Now let's come to the Affordable Care Act, and here it gets a little dicey. Last month, our electorate voted into office for the first time since Reconstruction a majority Republican House and Senate. Okay, I have a Democratic governor. Now, for those of you who aren't from the South, Democrat in the South means something much different than Democrat on the coast. All right? Democrats are pretty fiscally conservative across the South, so we don't have as much of a polarized situation maybe with an RD shift as you might have in a more progressive state. But we are going through a shift. Going back to this patchwork quilt, we've got 500,000 of our 3 million citizens that are uninsured, most of them working a full-time job, almost all of them in the target zone of either Medicaid expansion or the health insurance exchange. Remember, we talked about the disability. Well, actually, let me go back. So this is all 50 states by median household income. The gray bar is where Arkansas is at about $43,000 a year. Yeah, $43,000 for a family of 4. We've actually increased our economic situation compared to other states over the last 4 years because we have a forced balanced budget act in our state budgeting process. So our match rate has gone down. All right, our match rate, we're still over on the left. We get a pretty good match rate, but it's gone down from 77 cents on a dollar to 70 cents on the dollar. Now that doesn't sound like much, a 7% decrease, until you think that it's a $4.5 billion program. Each cent is a $50 million hole. All right, so this starts to be a real issue and a real driver on the payment improvement and the political argument about whether we can or should expand coverage. This was the same slide as before with the different eligibility requirements. Our our working parents are only eligible at 17% of the federal poverty level. So you can see what the difference going to 135% might be for our state. And I would say other states that tend to be over here on the left have the same potential benefit for your citizens. Here's the difference in our benefit structure if we move. So for a jobless adult, they can make $1,452. That's 13%. For a working parent, a little over around $2,000. They have to have fewer than $2,000 in assets, and they have to be disabled for 12 months to be eligible today. If we have the potential, we can go to 138% or $15,000 a year, have no assets, have no disability requirements, and it's about 250,000 people of the 500,000 that are uninsured that we believe would be eligible for Medicaid in 2014. We can get into the discussion on it. It's 100% federally funded for the first 2-3 years, and then it scales down to 90%. That's better than any state's match rate right now. So again, we can get into that in some of the discussion. Now we do next year have a projected Medicaid shortfall. It's $300 million in general revenue. Roughly at 3-to-1 match, that's $1 billion out of our $4.5 billion program that we have a deficit. And we don't have enormous extra resources in the state general revenue at this point in time. The cause, I mentioned the reduction in the match rate. We also have used stimulus funds and our trust funds to supplement the growth in the program over the last 2 years. And we continue now to face the growth, which is why we've aligned the payment improvement to actually try to reduce, not to fill the budget hole, but our goal is just to reduce the rate of rise from 6% to 4%. And if we do that in 2020, it saves the state $1 billion. Okay, and it starts to scale up. The executive recommendations are to fill the budget hole by half. We'll see when the legislature comes in if they're willing to fill the other half of the budget hole to keep the Medicaid program as it is now. But importantly, we have systematically gone through every program in the state to say, if we expanded coverage, what could we get rid of? Or who would we help? So we've actually looked at the opportunity to help catch up to the richer states. We've also recognized that we've got a fair bit of uncompensated care that's red ink on the providers. Their constant then goal is to shift costs back over onto the payers, public and private. But finally, the 100% federal funding, and our governor, along with some of yours, asked for and got in writing the opt-out option so that at some point in time you can cease to participate in the program. There's no obligation to continue. It takes over for our existing patchwork of funding. It relieves the state from our uncompensated care. It assists, importantly, county and municipalities that are bearing that, county hospitals, county jails, correction department, that are caring for the uninsured. And we estimate that it's at least $1 billion in new funding coming in each and every year and going out to those dark blue areas of the state, the rural parts of the state where the uninsured are most highly concentrated. We've walked through the numbers, and just to, at a pretty high level, these are Andy Allison, our Medicaid director's forecast that he put in front of our budget committee in the legislature. So these are now in the budget proposed if we did expansion. If you do new expansion, you're going to have what's called a woodwork effect. People who are currently eligible but sign up. And you have to pay, we have to pay 30 cents on the dollar for every one of those newly eligible woodwork effect folks. So we're going to have to spend $25 million new dollars in the first year. But we have Medicaid savings in that people who sign up for the full benefit plan won't come over and take the partial benefit plan of pregnancy or family planning. Our HIV patients can be on the full benefit plan, not the partial benefit plan. That patchwork we'll get rid of because we'll have a full benefit model. We think if you put $1 billion out, you're going to generate some tax revenue back. We're pretty conservative on that. It's saying we'll get $31 million on $1 billion spend in tax revenue. But this is a conservative budget in a conservative state with a conservative legislature. We don't want to count what's not there. And finally, there are programs in other aspects of state government that we need to pare back. We run a breast and cervical cancer program out of the health department. If we have a full benefit program that covers those, we won't need as much there. We run community mental health service clinics with 100% state general revenue. Because the benefit covers mental health, it ought to be, those clinics will still be there, but they should be paid by the benefit, not supported by 100% general revenue. So when you add this up in the first year, if we're aggressive, we think with coverage we could save $115 million of general revenue, not necessarily all in the Medicaid program, but across multiple state budget line items in the program. Over time, in 2021, we have to start paying our 10%. That's up at the top. So our Medicaid expansion costs jumped from 25 to 152 million, but we're still coming out with 250,000 newly covered lives for in 2021 cost us $28 million a year in a pretty conservative estimate. That's if we are aggressively looking at every other budget line across state government of where we are offloading state pure general revenue expenses for what becomes a covered benefit under the Medicaid program. This is our goal. The patchwork quilt below, we've gotten rid of the disability and the asset requirements. The salmon colored here is the Medicaid expansion. We think there are 250,000 people there. The conservative estimate of $1 billion, Andy and I played back and forth. I think we can do better than a conservative estimate by getting people enrolled. That could go up to $1 billion, $1.5 billion. Our insurance exchange, we're operating a state and federal partnership. We could not get our legislature to support a state-only exchange. So we're doing a state and federal partnership. We think there's another 200,000, 150,000 folks that will be privately insured, and that there's another $1 billion in private tax credits that could flow into the state depending on how that shakes out with our employer base. So this is where we're going. It takes 75% of both the House and the Senate to get there, and we're not asking yet. But we come into session in January, and this will be the topic that's a major one for our legislative body to decide. I just want to put up here a few things that the Affordable Care Act does not solve, in addition to the federal fiscal cliff that everybody's watching. It does not solve the sustainable growth rate provision that says on January 1st, Medicare physician payments get cut by 29%. Congress has always kicked that down the road, but it doesn't even touch it. It doesn't address workforce needs. That's why we did our strategic plan on workforce. It doesn't have the cost containment. That's why we're doing the payment improvement initiative. And it doesn't address the budget shortfalls in its entirety unless we actually choreograph this so that we're expanding Medicaid, we're cutting other agency budgets because they should be billing Medicaid now, and we actually are moving to a better place from an economic position. ACHI.net is my center's site. We're trying to keep up with this, and from there you can navigate to payment improvement or other sites that we have going in the state. So thank you. Look forward to question and answers.